So good morning, good afternoon, or good evening, depending from where you are joining us. Multiple sclerosis is the most common chronic, inflammatory, demyelinating, and neurodegenerative disease of the central nervous system in young adults. This disorder is a heterogeneous, multifactorial, immune-mediated, progressive disease with no cure so far. Thus, given the progressive nature of this disease, it's very important to know how to expedite the diagnosis and treatment of MS, because a treatment that can slow its course appears to be more effective or most effective when started early. Several lines of evidence demonstrate that tissue damage occurs very early in the disease, and much of this damage is clinically silent. Tonight, the IVPN NeuroPsychiatry, in collaboration with Jensen, is organizing a 2-modules educational activity, during which we will all learn from top MS experts the basics of multiple sclerosis disease, from diagnosis to management. So thank you, Jensen, for sponsoring this course. Our first speaker, Professor Naji Riashi, will discuss the epidemiology, phenotypes, and pathophysiology of multiple sclerosis. Dr. Riashi recently joined Sheikh Shakhbout Medical City as a consultant neurologist and Khalifa University College of Medicine as Clerkship Director of Neurology and Assistant Dean for Clinical Affairs. Prior to that, Dr. Riashi was tenured full professor and chair of the Department of Neurology at the Lebanese American University in Beirut, Lebanon, and assistant dean for clinical research at the LAU Gilbert and Rosemary Chagouri School of Medicine, also Lebanon. Born in Beirut, he received his medical degree from the American University of Beirut. He then pursued a 4-year postdoctoral research fellowship in neuropharmacology and neurochemistry at Case Western Reserve University in Cleveland, Ohio, and completed his residency in neurology at the University Hospitals of Cleveland. Subsequently, he joined the Cleveland Clinic Foundation for a 2-year fellowship in epilepsy and clinical neurophysiology. He is a diplomat of the American Board of Neurology and Psychiatry and diplomat of the American Board of Epilepsy and Clinical Neurophysiology. He is member of several scientific societies, including the American Academy of Neurology, Lebanese Neurological Society, and founding member and past president of the Lebanese League Against Epilepsy. His areas of expertise include epilepsy, multiple sclerosis, headache, and cognition. Dr. Riashi is also actively involved in teaching, assessing, and mentoring medical students, resident, and fellow. He is an active researcher and has been involved in several clinical studies. He is an editorial board member of several leading journals and the author of many peer-reviewed publications and book chapters. Dr. Riashi, we are honored to have you as a speaker with us tonight. Welcome, and the floor is yours.
Thank you, Maya, so much for this kind introduction and for the invitation to participate in this seminar. I'm honored and very pleased to be here with all of you tonight. Can you all see my screen? Okay, perfect. So I have the task of discussing with you all the pathophysiology and the epidemiology of MS. And as Maya just mentioned, it is a very debilitating disorder that affects not just the white matter of the central nervous system, but more recent information has also proven to us that the gray matter is affected as well. It affects the central nervous system, both the brain as well as the spinal cord. So neurons and different types of neuroglial cell will constitute the central nervous system. And as you know, each neuron will have an axon that is going to be myelinated, so covered with myelin to insulated, so that the action potential gets propagated across it quickly and then reaches the effector organs. The oligodendrocytes are the ones responsible for the production of the myelin in the central nervous system, And we also have microglial cells that are important in inflammation, and astrocytes that will present a supporting framework for all of these cells and will help in the phagocytic functions of that neurons. Now, as I've told you, the axons of the neurons are covered with myelin, and myelin looks like an onion sheet. So it is circular, as you can see on the right-hand side of the slide, and it will cover the neuron, and it can regenerate. So if we have an axon that loses part of its myelin, it has the possibility to get at least a portion of it back. Now, the blood-brain barrier is a very important structure that will need to be bypassed for cells to get inside of the brain and produce their effects, whatever these are going to be. And unless we need those cells and we suck them in through receptors or channels, then they cannot access the brain unless they break down the blood-brain barrier to be able to enter. After this introduction, let's get to multiple sclerosis per se. And as was mentioned already, it is a chronic inflammatory demyelinating disease of the central nervous system. It was first described in 1866 by Charcot and Vulpian, and it is characterized by plaques. Multiple sclerosis is several plaques put together, and the plaques are disseminated and they are found on the surface of the gyri and in the spinal cord, and they will be variable in their location. It is, as was mentioned by Maya a little bit earlier on, the most common chronic neurological condition of young adults, both in Europe and in North America. And I think that's fair to say that this applies to our population in the Middle East as well. It is an inflammatory demyelinating disease of the CNS, but not just demyelinating. We also have axonal transection, as I'll show you in a little bit, early on in the disease. The signs and symptoms will be multiple and they will be variable. So there is not going to be a characteristic presentation of patients with multiple sclerosis, and the natural history will be variable as well, and we will dwell on that in a little bit further in the presentation. The three components are going to be inflammation, demyelination, and axonal loss. The data for inflammation can be seen here. This is a blood vessel in the middle, the red, big red blob. And around it is all of this inflammatory exudate, which will be constituted of several different types of cells, as we will discuss in a little bit. And they will be very densely present close to the blood vessels in areas that will be affected by MS. Now, we mentioned demyelination several times, and we've already said that an axon will be covered by myelin, and the action potential will be transmitted in a saltatory way, so it will jump from one node of Ranvier in between the myelin sheets to the other to reach its destination very, very fast. When the axon is demyelinated, this will slow down if it will not stop completely the conduction of the action potential. And what we will see with time when the demyelination will become chronic is further increase in the density of the sodium channels that will allow conduction to be restored, albeit at a slower rate. This is when this happens, or we might be unlucky and have a complete transection of the axon, which will lead to its destruction. Now, data from Trapp and his colleague was published at the Cleveland Clinic in the 90s that showed, and this is an electron microscopy that showed you these big blue blobs. These are the transected axons. And here we see also the linear blue portions of axons that are demyelinated. And this was demonstrated in patients early on in the disease and not later when we thought that they are completely burned out and this is where the axon will be affected. And this revolutionized the way we thought about MS and our thinking about this diagnosis. The fact that we had these early axonal loss that would occur in an MS patient. So what will be the proposed correlation between the clinical course, the axonal loss, and the neuronal loss? Well, early on in the disease, we will have a relapsing remitting phase of the disease, and I'll discuss this in further details later on. And in between the relapses, the patient will go back to a normal or non-progressive state. And then at one point in time, the disease will change. This is the natural history of the disease when it's not treated, into what is known as the secondary progressive MS, in which we'll start seeing progression even in between relapses. And all along this time, we will have axonal loss that will accumulate. Now, the CNS will be able to compensate some at the beginning, at least, for this axonal loss, but at one point in time, we will reach a point where the CNS will no longer be able to compensate, and we will start having an irreversible neurological disability that will accumulate with time and will become very obvious in the exam or in the daily activities of the patient. Now, the pathogenesis will involve, as we have already discussed, demyelination and axonal transaction that will result from the inflammation that will be seen within the central nervous system. And we think that this is due to an autoimmune disease. Unfortunately, we do not have good animal models to be able to study multiple sclerosis. There is one that exists in mice. It's called the experimental autoimmune encephalomyelitis, or EAE. But we cannot, unfortunately, transfer any kind of information from the mice to the man or to the human being. And these two entities, EAE and MS, are really not the same disease. However, there are some basic proteins, proteolipid proteins, that were detected in EAE and that will be able also be present in MS that we can measure. What about the inflammatory mechanisms in MS? How are they mediated? Well, they are predominantly mediated through T cells. And for a long time, we used to think that B cells do not play any role in the mechanism involved in the inflammation seen in MS. But now we know better. And there is data that has accumulated over the past few years on the role of B cell, which shows that they play a very, very important role. And this is demonstrated through all of the B cell therapy, which has been proven to be extremely efficacious in treatment of these patients. However, the T cell mediated inflammatory disorder will involve lymphocytes, macrophages, and plasma cells that will be seen in the plaques, in active plaques of MS. And whenever we are dealing with cell-mediated immune abnormalities in MS, we will also observe an increased production of cytokines and increased levels of the adhesion molecules. And we will start seeing rapid migration of the T cells from the blood to the central nervous system. And the decrease in the T cell suppressors will be observed simultaneously with all of the above mechanisms. So the plaques are going to be the characteristic lesions of multiple sclerosis. They are going to be extremely well delineated, and we will see in them areas of inflammation and of destruction of oligodendrocytes, and sometimes also transection of neurons. And they are going to be widespread in the central nervous system, white matter, even though they have areas of predilection in which we will be more likely to find them. And these will include the periventricular regions, the optic nerves, the brainstem, the cerebellum, and the spinal cord. So there are going to be several different types of plaques: the acute active, the chronic silent, and the chronic active. How are we going to be able to differentiate between them? The acute active will have areas of perivascular lymphocytic infiltrates in areas of inflammation. And we will see a lot of macrophages that will be filled with myelin-related degradation product. the chronic silent plaques will be filled with demyelinated and transected axons, and we will see areas of gliosis, but we will only see a few lymphocytes and macrophages, if any. Sometimes a chronic lesion may become active again, and this is what we call a chronic active plaque. And in these plaques, we will have the central region that will be very similar to the chronic silent, but at the periphery, we'll see active inflammation, and that region peripherally will be very similar looking to the acute active plaques. Now, what are the points that implicate the immune system in the pathogenesis of MS? We have three different factors to look at. First of all, the histology, and when we look at the plaque morphology, we have evidence of inflammatory infiltrates, as I've just discussed with you, that will contain activated lymphocytes and immunological mediators. Then when we look at the laboratory findings, and in patients with MS, we like to obtain a sample of the CSF from the spinal cord. And when we analyze it, we demonstrate in these patients that have MS that they have an intrathecal IgG synthesis. So the IgG synthesis will be higher in the central nervous system in the brain than in the serum. And we, to be able to demonstrate that, we look at something that we call the IgG index, that will compare the level of the IgG in the central nervous system to the serum, and that will show that the synthesis of IgG is much higher in the central nervous system than in the serum. And the same will be true for the oligoclonal bands of IgG and for the activated lymphocytes. They will be much more likely to be seen within the CSF. Now, there is a third factor that we need to look at, and this is the therapeutic or all the modalities of treatment that have been shown to be effective in MS, and those all include immunosuppressants and immunomodulators. Now, there is a geographic distribution that is very important to know about in MS, because there is an increased prevalence of MS in the temperate regions that will be more frequent in higher latitude than whenever we come closer to the equators. And this will help us determine areas in the world of low, medium, and high risk, depending on their geographic location. And why that is really unknown to us. There is definitely a mix of genetic and environmental issues. Now, this used to be the map that would describe the areas of high risk in dark orange, medium risk in mustard, and low risk in yellow. However, we now know that this is no longer absolutely true, because areas of the Middle East and Gulf, for example, that are supposed to be low or low-medium risk are found to be high risk. I cite as an example Iran, for example, where MS has reached endemic proportions, whereas it's supposed to be in a low-risk area or a low-medium risk area. Now, the etiology of MS is still unknown up to this day. We know that there is an autoimmune disease that is involved, and we know that genetically susceptible individuals are more likely to develop this autoimmune disease. But we also know that there are environmental triggers that will need to be involved as well, because the genetics do not explain everything. Unfortunately, we were not able to isolate a single causative agent of this disease. And there is a possible explanation that says that a virus will induce a T-cell mediated immune response that will lead to the production of self-antigens that will be sustained and will continue to produce the destruction that will lead to MS. Now, what is the pro-evidence that genetics is involved? Well, we have very high rates of prevalence in Scandinavia and in Midwest of the USA. Why? Because a lot of the population in Scandinavia migrated to the Midwest and carried along their genetic pool with them, and led to the increase in prevalence in this region of the US. The other information is that there is an increased risk from 1 in 1,000 to 1 in 100 in a person with a close family member with MS. The third piece of evidence comes from identical twins. An identical twin of a person with MS carries a risk of 1 in 3 of developing the disease. And also we have many multiplex families that have been isolated with potential chromosomal loci. It is important to cite that one of these families was located in Sweden. And when we looked at the background of this family, they originated from Lebanon. So it is amazing to see that. Now, the pro-evidence shows us that in a first-degree family relative of patient with MS, the absolute risk will become less than 5%, which is 20 to 40 times higher than the risk of the general population. In monozygotic twins, as we've mentioned, the concordance rate is much higher, 31% compared to 5% in dizygotic twins. And also that the presence of the HLA-DR2 allele and others alleles that have been detected since will increase the risk of MS. What is the con evidence of genetics? Identical twins of persons with MS do not always get MS, as was shown in the previous slide. And more than 80% of the people with MS do not have a first-degree relative with MS. So we know that MS is not directly inherited, and we know that genetics is not the only factor to be involved. What about the prevalence? There is this recent paper by Wallen and his colleagues that was published in Neurology in 2019, and that looked at both private insurance as well as governmental insurance in the US, applied this validated MS algorithm to the administrative health claims, and got us these numbers. So the estimated 10-year period prevalence between 2000 and 2010 for MS was overall 309 per 100,000 individual. So this led to a total number of about 727,000 plus patients with MS in the US. And an estimated lifetime prevalence for 2017 came up with an overall 362 per 100,000 for a total of 914,000 cases of MS. Again, on the right-hand side of the slide, you see that women are much more likely to be affected than men, with a ratio of 2 to 3 to 1 for women versus men. What about the MS prevalence rates in the MENA regions by decades? And this paper was published by Dr. Yammout and his group. And they looked at 1970 to 1990, etc., up until 2015. Each bar represents a single study, and you can see the various prevalence rates that are published for our regions. As I've mentioned before, sorry about that. Gender is important, as we have a female to male prevalence, with the female ratio being 2 to 3 to 1 for male. And it is a disease of the young. So middle years are much more likely to be affected, even though the range goes from 10 to 60. Usually the typical onset will be between the ages of 20 to 40. It is uncommon before puberty. It is unlikely after 60. So when you see it in this age group, you have to look further to make sure that this is the right diagnosis. And 75% of the diagnosed cases was seen in patients aged 35 to 64 years. There is a neuroendocrine interaction because pregnancy improves and contributes to protect against MS, and there is an exacerbation of the risk that is seen in the postpartum period right after the delivery. And this just summarizes these points. And in addition, we have an ethnicity that is involved, with Northern US Caucasian and Canadian whites much more likely to be affected than the Australian or the South African, who are also more likely to be affected than the African blacks or the Oriental. What is the first symptoms of MS? Weakness is very likely to be there. We can have also followed by optic neuritis and paresthesias, and less so micturition problem and vertigo diplopia runs as well highly within the first symptoms of MS. What are common symptoms of MS? All of the ones listed here, and amongst them are two that we were taught were not involved in MS, and by that I mean pain, cognitive decline, and fatigue. We were told that MS does not cause cognitive decline, and this is because what we use to measure it is the mini-mental status, which is not efficacious enough to be able to detect these changes. The symptomatology of MS, as I've mentioned before, there is no typical manifestation. We can have both physical and cognitive disability, and this will be occurring irrespective of the physical disability and early on during the disease. 50% of the patients with MS might suffer from cognitive impairment. The clinical course is variable and will follow 4 types, and it will be summarized in this slide. We will have the relapsing remitting MS, which is the most common and occurs in about 80% of the patients with MS. So we'll have a relapse, and then we will have a period where the patient is stable with no further exacerbation, and then another relapse and another area of stability. This may, in time, if the patient is not treated, convert to a secondary progressive form of MS, during which we will, during which we will see progression in between relapses. Compare and contrast this to the primary progressive and the progressive relapsing. The primary progressive accounts for 10% of the cases, and we will continue to see progression all along and less relapses. And when we have superimposed relapses on this course, it will become a progressive relapsing, and it accounts for about less than 5% of the total cases. So this is the classification as I've discussed with you. I'm going to go quickly with that, and I will stop here, and I will be able to entertain any of your questions. Thank you very much for your attention. Maya, or how do we go about questions now?
Sorry, doctor, I had a problem unmuting my laptop. So we will take a question, and I will be taking any question. First of all, let me thank you for an excellent presentation, and we will take any question from the audience. So one of the question is, what about the risk factors for multiple sclerosis? So we have a new emerging data about EBV infection as a cause for MS. Can you elaborate on this, please?
Yes, actually, EBV was shown to be definitely associated with a higher risk of MS. We have data to corroborate this finding. So whenever we have an EBV infection, the risk of MS goes sky high. Other risk factors would include vitamin D deficiency. That's why we like to supplement our patients with vitamin D. Unfortunately, we were not able to isolate other viruses besides EBV so far.
Thank you, doctor. Another question. What is the most common presentation of MS? So what are the most common symptoms that usually patients presented with?
Yes, as I've mentioned, one of the most common presentation is weakness. We have weakness that may involve a hemibody, or it may become a case of transverse myelitis that involves the spine, and both lower extremities might be affected, and this might be associated with sphincteric incontinence. We have optic neuritis that can also present very commonly as a first symptom in MS. We have paresthesias that are also very common. We have brainstem and cerebellar findings that could also be seen early on in MS. So these are among the most common presentations of MS.
Another question, a patient presenting with seizure, do we suspect multiple sclerosis? So is seizure one of the presenting symptoms for multiple sclerosis?
Usually not, because as I've mentioned, MS starts by affecting mostly the white matter, whereas seizures would need to involve cortical lesions. So usually when we have patients with seizures, MS is not very much a culprit in our diagnosis. However, there are cases tumefactive MS-like lesions that have been involved in the diagnosis of seizure. But usually seizures are not caused by MS.
A final question, pediatric MS, does it have the same presentation as adult MS?
It may. Kids might present with weakness, they might present with paresthesias, they might present with optic neuritis. So yes, it may have the same presentation.
So with this, those were the question received from our audience. So thank you again, Dr. Riashi, for this amazing lecture. And we'll be moving to our second top-notch speaker, Professor Muhammad Al-Jum'a, who is joining us from Saudi Arabia. So Professor Muhammad Al-Jum'a is a professor and senior consultant of neurology at King Fahd Medical City, Riyadh, KSA, with over 25 years experience as certified neurologist. He is the founding member of the King Abdullah International Medical Research Center. Also, Dr. Muhammad is an experienced healthcare leader. He has served as a chair or a member of many of the national and institutional committee. But he is a founding member of the National Committee of Biomedical Ethics. As a healthcare provider, academician, and researcher, he has a broad base of national and international network that has enabled him to have an extensive experience in the regional needs, challenges, and opportunity in healthcare industry. And with more than 28 years experience in the healthcare field, Professor Al-Jum'a has several key positions in healthcare industry and has worked extensively with the Ministry of Health in policy planning and advocacy. And since MS diagnosis is not always straightforward and many factors can help perpetuate the misdiagnosis, Professor Al-Jum'a will highlight the diagnostic tools for MS. Professor Al-Jum'a, you are always the most welcome. Please start your presentation.
Thank you, Maya. I'd like to thank you all for attending this webinar. The logo on the right is the Saudi MS chapter, which is part of the Saudi Society of Neurology. These are my disclosures. And what I'm hoping to cover with you today, some of the points will be repeated. However, we'll talk about MS as a disease. We'll talk about the importance of diagnostic criteria before really going into the criteria which we use to diagnose now currently. The common clinical presentation that we usually use to diagnose, what are the tests that we use, what are the mimickers which are usually making it difficult for early presented patient to be labeled with MS, and hopefully we'll be closing with the what would be next after diagnosis, which will be part of the conclusion, and that what you will cover in today's webinar as well as in the coming webinars for part 2. This slide represents what really a summary of what was presented in much more details by Dr. Riashi. The disease is heterogeneous, and that heterogeneity is making it sometimes, if the patient presented in a typical way or certain time presentation early on makes it difficult. The disease, we know it's autoimmune, and it as well interact with many other autoimmune diseases, which at times complicate the picture. You knew more about the epidemiology, but the important things, which is as well to go into the causes, it's usually a mix between genetic and environmental trigger, which is usually in certain susceptible individual will have the chance to develop multiple sclerosis. Dr. Riyashi covered elegantly the change in scope from focality into much more diffuse damage. And I'm presenting this not really to go over that, but that would tell you why there are so many mimickers. Because the disease in the past, we know only the focality, which present with the certain presentation or certain images on the MRI, but as well we know now in the pathogenesis that it's much more than that, and it's diffuse, and any disease which really have the mixed presentation, usually there will be certain patient that will be mimicked or have difficulty to diagnose. Why it's important to diagnose MS? Because it is the most common cause of disability in young, if we exclude the non-traumatic causes. When we talk the impact of the disability, it's really huge. And I'm not really going to cover this, but it has an impact on the individual, society, as well as healthcare system from both the direct and indirect costs. And in the epidemiology, really, we know now that nobody's immune. However, there's a certain group of people, certain age, who are much more susceptible. Things has changed. And the way that we are diagnosed has really improved with the more therapies are available. And the more therapy which we have, which are the much more specific, we always improve our diagnostic criteria to make sure that we identify and treat patient early. And I'm sure that in the next lectures, as well as in the part 2, you will know the importance of early treatment and early identification of patients with multiple sclerosis. This is just to give you the diagnostic criteria. Since we don't have a single diagnostic test or typical presentation of MS because of what you have learned in the early lecture about the pathogenesis, we have been evolving on the way that we diagnose MS. Yes, the disease is the same. The symptoms are the same. However, we are having much more better tool as well as much more knowledge, and we are integrating more data that we have to make early diagnosis. Schumacher criteria, which was used for a long period of time until the clinical trial came in with the therapy with Poser criteria, which really was much more complicated really to pick up the patient early, but they were able to diagnose well-established patient. Then when therapies became available, we start to notice that we need to improve our criteria, where McDonald's criteria was created by a group of experts. That criteria has evolved from 2001, which was discovered, to almost 2017. And that evolution has really helped the patient as well as the medical community to diagnose and treat and prevent disability early in the patient. Just one example of how the evolution of the criteria has really changed. We just see the typical age of diagnosis. In Poser criteria, we're diagnosing almost at end of third decade. When we start to apply McDonald's, we were almost in the middle of decade, not much change a little bit, but with the improvement between 2005 and 2010, we dropped that by almost 25% to 30 years old, which are the typical age of diagnosis. I'm sure, and everybody who is in clinical practice know that McDonald's criteria 2017 has really moved to earlier diagnosis. And I'm sure that we are picking up patients much more earlier, but we don't have yet the data accumulated since 2017. The more we treat early, the better we prevent disability. And just whenever you pick up people early diagnostic treatment, you keep them in the early or the light blue. The more delayed, then people, as Dr. Riyashi has talked to you about the impact of the pathogenesis and the impact of the destruction of the axonal as well as the neuronal cell. There will be a deficit that are or even if you start treatment, this disability will persist. the way that we diagnose MS, and from now on, I'll be talking about the diagnostic criteria mostly, is as a neurologist, and when you go into clinical medicine, we depend a lot in clinical history as well as physical examination. Actually, the most of the time, neurologists are almost 90% accurate in their diagnosis by getting a good history and good physical examination. And those are skills that we developed over the years, really, to localize and then limit the differential diagnosis. And that's the most important step, really. Once you have suspected a patient with MS, then you go on and apply the diagnostic criteria, which will go into much more extensive in each of those, from both clinical signs, symptoms, and then what are the clinical and paraclinical evidence which we use to diagnose MS. Most important one is what we look into all the criteria. It's dissemination in time and dissemination in space, which is you need those if the patient presented with one event or two. But if they are recounted, mostly these are not important. These are important diagnostic criteria to pick up patient early and to start treatment early to prevent long-term disability. We'll go more on this, but then we use the MRI. We use the MRI, which is usually it's to confirm what we have and to see the typical lesion. Sometimes you don't need even images to diagnose, but we still do it to exclude other causes. We don't do much of the lab tests or serum except to really exclude other things. CSF studies, Dr. Yashi talked about the urocanal band, which really I'll show you that has been used from a biomarker or a marker of sphericity to a diagnostic entity or help in the diagnosis. We use as well in neurophysiology, mostly the evoke potential to identify as well dissemination on space time and mostly on the optic nerve. And whatever we do, we have to make sure that we don't have a better explanation of the patient's symptoms and signs rather than MS to diagnose the patient with MS. The typical clinical feature, the age is one, which has been covered early on. It has subacute onset, which is not really typical, like when we talk about vascular, which is very acute, or in the epileptic, which is sometimes semi-acute, but much more shorter than the subacute, which goes over a few days. It could have focality or multifocality, although the patient has a progressive or more diffuse symptoms, but those are with the progression, and they are difficult really to use in the diagnosis. The symptoms progress over hours or days. It's usually continuous. It should last more than 24 hours to say, well, these symptoms are persistent, and we should use them to make the typical presentation of MS. And usually a lot of them, because it's relapsing remitting, many of the symptoms would improve spontaneously. Some patients left with disabilities, but many, we talk about 70% from the typical presentation, which is relapsing remitting, that these symptoms would improve. Although there's a lot of symptoms that were mentioned in the previous lecture and this one, there are typical feature or typical presentation that we usually use, or when they come or the patient present with them, usually they push us into that suspicion. One of them is optic-neuritis, especially if it's unilateral, partial spinal cord syndrome, or brainstem syndrome, and I'll go over each one of those in a little bit more details. For the optic-neuritis, the typical presentation is reduced visual acuity in one eye, which is either it's acute or subacute, but majority are subacute. There are pain with eye movement, which is typical for optic-neuritis. Usually the vision is better than no light perception. Usually that the patient do not lose vision completely. They at least perceive light. Because the pathogenesis is on the optic nerve, usually the color is the first thing to get impaired, especially red color. And when you examine the patient, the typical finding is one optic nerve involvement, where you see the apparent defect with mild or no swelling and no hemorrhages. There are the atypical one, which is bilateral, no pain, no light perception, complete loss of vision, moderate to severe disc swelling, and there are so many other symptoms which, when you have it with the optic-neuritis, you make sure that, or it will raise your suspicion that maybe as well these patients, we need to work harder on identifying or to exclude other causes to make sure that we don't miss the diagnosis. Just to make the picture clear, let me go over 3 patient scenarios who presented with optic neuritis, and just to see the difference in how things will be easy if you really go on a detailed history exam. The first one is the typical presentation. The second one is a clinical presentation that are atypical, and the one that is not even in keeping with MS, and you don't even need to think of applying the diagnostic criteria because those should be excluded early on. This is the first patient who is a 33 years old man who came in with a blurred vision on one eye. And when you examined him, you could see that there is a failure of a deduction of one eye with nystagmus, which really goes with INO. When you look into the MRI, there are the typical feature on the prefrontal areas. When you look into as well the contrast enhancement, there's a ring enhancement, and you see the typical Dawson finger on the lateral views of the MRI. This is a patient who is really typical for MS. This is the second patient who presented again with the blurred vision. All the patients presented with a blurred vision. This one, however, he presented with bilateral painful loss of vision over 3 days. He has no light perception. And when you go into the other history, there's nothing really to help. But when you did the MRI, there are both optic nerves are involved, as well as the optic chiasma, which would make having the bilateral painful loss of vision in both eyes are usually not the typical presentation, although the vision or visual symptoms are common presentation, but not this one, which is bilateral, and that would make a suspicion of the diagnosis of NMO rather than MS. The third one is a patient with 33 years old man who presented with the blurred vision. However, those were very short for a few seconds to minutes, and they disappeared, followed by headaches, nausea, and vomiting. And this has been recurrent and coming to the patient over the last few years. The MRI the neurologist did an MRI, and there is one single lesion there, or even could be more than one, which is really small. And that you would know with this patient when you go take more history, you know that he has as well some visual symptoms and some even aura of the symptom with visual aura and zigzag lines that really give you the diagnosis of migraine headache. The red flags on the optic neuritis, although we did mention that the typical one, we mentioned the most of them, and they have been mentioned as well. But continuous sphere visual loss is something that would make it a red flag, and you need to look for other causes. Progressive worsening over 2 weeks, sphere optic disc swelling or retinitis, as well lack of spontaneous improvement or worsening after stopping steroids for a short period of time. Then you should look and to say, well, even if you diagnose your patient, you need to go back and re-look into the diagnosis. Again, the age, we talked about the typical age, and that has been mentioned as well by Dr. Ariashi. The third syndrome, which is typical as well, is the transfer myelitis, which is typically is partial myelopathy, not complete, commonly sensory pattern. Motor is usually asymmetric if there are most symptoms, and mild to moderate in severity. There is Lermite sign sometimes. Excuse me. There's urgency and incontinence. It could be as well in some form of progressive paraparesis, and there is no complete transfer myelitis picture or brown saccade, as we are going to mention on the atypical presentation, which really comes with brown saccade or quad equina or anterior spinal cord syndrome. You don't have those typical picture. When you go radiologically, there is the segment, which is only one segment, vertebral segment or less. Usually they are on the dorsal or lateral aspect. They are not usually central, but you could see them either lateral or dorsal on the presentation. And acute renal retention is not one of the as well typical presentation. For the brain stem syndrome as well, the typical one is a double vision, which is the INO that we usually see, unilateral sixth nerve palsy. You could see the cerebrospinal nystagmus and facial sensory loss or trigeminal neuralgia, and radiologically you could see the region which are preventricular, and the atypical one is complete external ophthalmoplegia, vertical gaze only, vascular territory syndrome, which is our typical one, and we know them neurologically when they present with difficulty as well. Dystonia and torticollis are not common. But whenever with these three syndrome, the common one presentations, you see the typical, you should think of the others. The other common presentation, which is motor, sensory, and so on, all these are really can be seen with many other diseases, but you need to look into neurologists as for certain causes. The clinical presentation is not suggestive of MS, are what as well mentioned, which when the patient presents with headache only, isolated fatigue, chronic widespread pains, intractable hiccups or vomiting, which is typical for an MO, and complete intermittent pulmonoplegia, rapid progressive dementia, encephalopathies, or systemic symptoms like optic ulcer or Zika. On those patients who are, their symptoms or signs are not suggestive, or when you see some symptoms which are you should not apply McDonald criteria. McDonald criteria, as we'll see later, they have been only tested in people with highly suspicious of MS. What are the clinical or paraclinical syndrome? We have talked a lot about the abnormal neurological examination and symptoms. The other one is the symptomatic lesion in the MRI, and also some of the typical one. Visual evoked potential or OTC are usually suggestive to only tell you that there is dissemination on the optic nerve if you do not have it clinically. And sometimes we use it for prognostic purposes only. In the CSF exam, we look only for olecranon band, and usually the misdiagnosis or the wrong diagnosis comes or can occur only for hysterical symptoms are used. And as we have gone to the McDonald's criteria, you see that sometimes we use hysterical symptoms. When you use them alone without really looking for the evidence, that would create an opportunity to misdiagnose. These are the typical MRI feature, which is either preventricular lesions here or there, as we saw before, in the lateral, the Dawson finger, and as well the juxtacortical one, which we can see them as well here in the juxtacortical area, which is just close to the white matter, cervical, which is shorter, as well as they are usually lateral or dorsal, but not central. When we look into the ring enhancement, in NMS, it's typically or usually it's not complete, and it's an open ring, not complete ring. We could see a complete ring, but the commonality as well is to see the open rings. The olecranon band is we use it to see bands on the CSF, present on the CSF, but not in the serum, and we use always a control to do it. And I'm not going to talk about the index. The olecranon band has in 2017 has a lot of weight to diagnose as well MS, especially on the patient they do not have the two event or two lesion. The diagnostic criteria we used a lot in 2010, and 2017 showed a clear differentiation, and there is a clear changes which are either revision or addition, and that has been really has pushed a lot of narrowing the window of CIS. We diagnose patient much more earlier now, which is good for the patient and good for response to treatment as the data are accumulating. And I'm sure this will be covered on either later today or in the next session. The revision one, symptomatic lesions are evidence of dissemination time and space, because in the past we were not using them. Cortical lesions are equivalent to just cortical lesions, so we count them now. In the past, we were not considering cortical lesion, but I think with Dr. Iyashi lecture, you showed how our understanding of the pathogenesis has changed. Diagnostic criteria of primary progressive MS has been as well developed, and now we diagnose primary progressive MS much more clearly, and we have clear diagnosis for it. The addition, as I mentioned before, olecranon bands is used now in the diagnosis. The specification for a professional disease course, which is, we'll talk or close with it. Now we have the relapsing remitting, secondary progressive, as well as the primary progressive, which is as well going with the new classification of of Lublin, that as well I'll mention if the time allow us in one slide. The determination of dissemination space and time are either through the MRI or diagnostic criteria is really one of the important supported things to diagnose MS according to McDonald's criteria. But the MRI remains the most useful test to aid in the diagnosis of MS, because it can show you dissemination both space and time. As well, MRI can substitute for clinical finding in determining the dissemination space. because if we find lesion in different area, like subcortical, not subcortical, infratentorial, or in the spinal cord, we can count them, which the spinal cord has not been counted for some time. These are the summary of McDonald's criteria 2017. If the patient presented with 2 typical attacks, and you took a good history, good examination, and you are certain, or you know that you have excluded other causes, or you may do some other tests to exclude the diagnosis. If it's more than 2, then your diagnosis is complete. Also, we do the MRI, we do sometimes more tests in the lab just to exclude other causes, but not really to confirm the diagnosis. If only one is presentation and the other one is historical evidence of a previous attack involving a lesion distinct from or in another area, like somebody who presented with optic and then historically has a hemisensory loss or some sensory loss, then those are 2 different areas, 2 different attacks, which all of them represent, and they typical for MS on time and duration. Then as well, the diagnosis is confirmed. You don't need other laboratory tests or MRI, but we do them to exclude other causes. As well, we do them as a baseline to follow up progression. If there is one site are affected on 2 attacks, let's say a patient has 2 attacks, but all of them are numbness and weakness on the right side, then it's the same side. Dissemination in time is there, but lesions with you need dissemination in space. But either you find a different lesion in the MRI, or you wait for further attack. But if you have the 2 attacks on one lesion, one side, then you need either supportive MRI or you need to wait for the second attack. If the patient presented with his first attacks, then you go for 2 more sites affected. Let's say somebody who presented with optic neuritis as well as ataxia. Then those are 2 sites, which is dissemination space. And then what you need to look for is dissemination on time with finding another lesions MRI in distant area from the others, or you wait for the second clinical attack. Or now, if you find an onochronal band on the CSF, that would give you the diagnosis. That was not there in 2010. If you have one side affected and just one attack, there is no, meaning that there is no multifocality, then what you need is again, you need an MRI to show dissemination space and time, which is a different lesion than the one that the patient presented with, or you wait for the second attack. Again, onochronal band would help to diagnose those patients. I hope this is clear because it really summarized the diagnostic criteria. I think for the time's sake, I'm not going to go into this, but it's exactly go and summarize what we did before as well, and to really going into diagnosis. Let's remember always that McDonald's has been done in the European community in patients with typical MS and has been validated in patients between ages 60 and 50. They are done to sole purpose to diagnose MS in patients whom MS is highly suspected, not to differentiate MS from other causes. Again, your clinical exam, your history, your other findings to make sure that you are within the typical feature, then you use the diagnostic criteria or McDonald's to confirm it, but not really to differentiate from the other. The quote in the down here is from the McDonald's criteria presentation, which tell you that we are not developed to differentiate MS from other conditions, but to confirm the diagnosis. Again, these diagnostic criteria need to be confirmed in people who are from different ethnic group, like Middle Eastern, pediatric SMS, late onset MS, general practice setting, or comorbidity when the patient comes with comorbidity. The differential diagnosis of MS is huge, and we don't need to go into it. Your good history and examination are really important to exclude majority of this list. However, the common ones are vitamin B12 deficiency, Casadel, ADEM, Defix disease, which is NMO, vasculitis, CNS syphilis, which is coming back, Jogner, sarcoidosis, Lyme disease, or CNS lymphoma. And all of these, they usually have a typical or some not typical disease. They have always give you something that will exclude the typical presentation of the MS, either clinically or the radiological presentation, especially on the lymphoma and ADEM. The common differential diagnosis, I'm not going to go into it, but in really in a center with patients who with 667 patients with suspected MS, a standard diagnosis criteria worked up, MRI, everything was done. A MS was diagnosed by McDonald criteria, and then they followed the patient for 3 years. Of even at those centers, 25 or 163 patients had an alternate diagnosis later on. 20 of them alternate diagnosis made, but the others were still suspicious, and although all the other tests were done. The common differential diagnosis in the one that are diagnosed, which is the small percentage, which is the 24, majority were non-specific or migraine. The other neuroinflammatory disorder like NMO, ADEM, or repeated optic neuritis rather than diagnostic neuritis, and systemic disease like Sclerosis in the small percentage. Most important cause of MS is misdiagnosis is incorporated or inappropriate application of diagnostic criteria, where you really need to push it and try to apply it in a patient who are not typical, because sometimes the criteria would fit, but again, the patient has a typical presentation. And inappropriate application of diagnostic criteria on historical episode, especially with those patients who come with one event, and then you go to the history and you try to fit it as well. You need to make sure in your history that that presentation is typical for MS. You could see now that to try to treat anyone, the most accurate or important point in the treatment is really accurate diagnosis. And once we diagnose the patient, we go into the pattern, which is whether they are relapsing remitting, secondary progressive, or if they are relapsing remitting, what kind is it? Was it active, highly active? And according to the criteria, which is really would help to select your therapy. But just the take-home message is optimal management of MS start with accurate diagnosis. And the key treatment decision steps to start with accurate diagnosis, accurate classification, and determining the disease activities. Once you get all of these correct, then you are really putting the patient into the right path to therapy and to prevent disability. The 27 McDonald's criteria introduced CSF finding as part of our diagnostic determination, which was not used before. The new criteria allows for an area diagnosis of relapsing remitting, restricting further CSS categories, and in different parts of the world, there are certain percentage of people who are still misdiagnosed. It took 1 more minute, but my apology for that.
Thank you, Professor Al-Jum'a, for a very enriching presentation and for accepting our invitation despite your busy schedule. Please allow me to take some questions. We have many questions, actually. So the first question, is primary progressive MS and secondary progressive MS one entity? It's a one disease?
Well, majority of people thinks no, they are not, because secondary progressive come usually after relapsing remitting, and that would make it actually continuation maybe of the relapsing remitting, and primary progressive is a disease entity that goes on. Actually, that raises even much more larger question. Are these the same? Are all of them are MS or no? Each one has a differentiation. I think we should wait for advancement in knowledge, identifying more biomarkers that hopefully differentiate people from. I think we have easily distinguished relapsing remitting from primary progressive. We failed in really identifying secondary progressive early on. And once we develop something that will help us to identify those patients early on, we'll be much more aggressive treating them to prevent them to go into that stage of the disease.
And talking about progressive MS, if a patient presented to you, he is already diagnosed at another clinic years ago and maintained on a certain DMT also, so he is treated. However, he is experiencing some worsening. How can you know if this patient is transitioning into an SPMS phase, or if he has SPMS or progressive MS, or he has uncontrolled relapsing remitting disease? Can you know from the first encounter?
Usually, you will be lucky if you know from the first encounter. Most of the time, you will have to go back to truly go back and examine the patient from the beginning. Take your history again. Take again, in neurology, we are good in taking history. We should be good in taking history and exam. If we are not good in that, then in the past, getting an MRI would take you months. CT scan was the only available modality when we start therapy. We depend a lot in our clinical sense. But I think for those patients, we should go back again for a good history examination. And most of the time, with a long historical period between the time that he was diagnosed and presented to you, after a while, you would really be able to pick up primary progressive from the history only. Or to say, well, maybe this is not. There are certain people who cannot, because we know that there are people which now with the Loveland criteria that there are maybe primary progressive and then they transition from inactive to active, and that would really tell you that maybe they are, which are really small percentage. Again, it's your history and clinical examination would help you to differentiate between patients who came and diagnosed as relapsing remitting. With time, maybe he was mislabeled as primary or not labeled as primary, or he's transitioned.
Another question, what is the role of evoked potential in the diagnosis of MS? So do we request them on all patients presenting to our clinic and on whom we are suspecting a diagnosis of MS?
I think if you have enough diagnostic criteria in your history and physical examination, you are not really somebody who's atypical, and you need to identify a subclinical optic neuritis, then you don't do it. I don't really do it except for the patients who present with visual symptoms as optic neuritis, sometimes not mostly to diagnose, mostly to compare what are the symptoms, and then we go on and maybe follow it up with the OCT. Now we depend much more onto the prognostic more than the visual evoked potential. I do them, but not commonly. I do them only in certain people who we are looking to really in the atypical, and we start in the fishing, or as a baseline for somebody who presented with, but not in somebody who presented with sensory and the motor and there is no visual symptoms.
Another question, it's not the scope of our lecture, but one of our attendees would like to know, how do we treat a patient with transverse myelitis?
Well, the transverse myelitis, if they come as a lone transverse myelitis, not really part of the other diagnostic criteria with them with NMO or the other, then you treat them only acutely, which we usually go with steroids. Pulse steroid for 5 days. Some people in the past, if they don't respond, they go for second dose. Now, if we are suspecting NMO, we go with plasma pheresis. But typically, steroid is your initial therapy, looking for what is the cause, whether it's an isolated transverse myelitis, post-viral, or post anything else, or it's part of another syndrome that you need to initiate maybe a long-term therapy to prevent relapses.
And a final question, as per the latest Atlas of MS published by the Multiple Sclerosis International Federation, the prevalence and incidence of multiple sclerosis has significantly increased over the past years. So do you think that this increase in the incidence and prevalence of MS is due to the improvement of the McDonald diagnostic criteria, or there is a real increase in the incidence of this disease?
Well, the improvement in diagnostic criteria helped in really diagnosing early. People with MS, they will be and will stay with symptoms until you make the correct diagnosis. I don't think it did help to increase the number or the prevalence. It did help, as we shown earlier, to get the diagnosis much more earlier, to start therapy earlier and to prevent disability. However, we know that the genetics are still the same, did not change. The triggering factor, maybe we are now exposing to so many things. We do now in one day what people used to do in a month. We meet so many people, we get a lot of things. I think it's mostly environmental, dietary things, which really in people susceptible has increased maybe the prevalence as well. We in our region, I think it's transition of age, because we have the majority of our population is young, below 18, which is not the typical age for presentation. The more we go into a larger population into an age onset of increased predisposition to disease, of moving from kids and adolescents to young adults, and we have a larger portion of our population, then our chances to find people would increase as well. And this is typical, and I think it's the same in all Arab region except in Lebanon and Tunisia, because there is the growth of the population has been really evolved earlier than the others.
Yeah, true. Thank you, Professor Al-Jum'a, for being with us tonight. We will move to our next session, which will be presented by Dr. George Saab, who will elaborate on the tools used to measure disability in multiple sclerosis and the tools used to monitor clinical worsening or stability. Dr. George Saab graduated from the American University of Beirut in 2019 as a neurologist, completed his fellowship in MS at the Therese and Naomi Tommy Multiple Sclerosis Center at the American University of Beirut in 2021, and he is currently completing a second fellowship in MS and autoimmune neurology at the Barlow Multiple Sclerosis Center at the University of Toronto, Canada, which is the largest MS center in North America. Dr. Saab has several publications and ongoing projects in neurology and multiple sclerosis, and is passionate about finding alternative method of treating patients with MS. Welcome, Dr. Saab, to our webinar tonight. The floor is yours.
Thank you very much, Dr. Zainuddin. I'd like to thank you for inviting me to this webinar, and thank all the panelists as well, and thank Ms. Joy Masuh as well for that. I'm going to share my screen now. All right, can you all see my? Right.
Yes, we can see.
So thank you. So I'm going to be talking about the Expanded Disability Status Scale, or what we call the EDSS. It's technically one of the major tools that should be known in patients or people who treat MS or who are targeting multiple sclerosis. For my disclosures, it's organized by IVPN with the support of Janssen Pharmaceuticals. So, as an introduction, in 1868, MS was described by Jean-Martin Charcot, and then the DSS, or the Disability Status Scale, was introduced by John Kurtzky in 1955 as 10 steps. So technically from 1 to 10, a total of 10 steps. Including 0 initially, which is also what we're going to be talking about in a bit. Then in 1983, it was modified to become the Expanded Disability Status Scale, which was 20 steps. Now, it's technically a language. If we want to describe it in one simple method, it's a language that people who deal with patients with MS use. So instead of me describing a patient's deficits or what a patient has on their exam or so, the EDSS is a language that makes it much easier for everyone to understand. It's a universal language also used in research studies mostly to really evaluate patients. Now, in 1983, John Kurtzky said the following: we thought we had found a possible therapy for multiple sclerosis, which was isoniazid. To measure any effects of therapy in MS, and they therefore had to monitor whether this treatment was helping or not helping, or whether the patients were worsening or not. The first question was exactly in what were we trying to find changes caused by treatment. So instead of just describing that the patient has a certain deficit, this number that's the EDSS was a much easier way of describing that a patient has a deficit or does not have a deficit, and how big the deficit is. So it's a number that goes up from 0 up to 10. It has 20 scales because it has a 0.5 scale. So it starts with 0, then goes up to 1, 1.5, 2, and so on up until 10. And the more you go with the number, the higher the number, the worse the patient is. The 0 is the normal patient with a normal physical exam. So it has constituents. In order to get this number, you have functional systems, which are the FS scales or the FS scores, which each represent a network of neurons in the brain with responsibility for a particular task. So technically, each FS or functional system is responsible for one of the neuronal networks that are present in our brain and spinal cord. For example, there's the visual FS score, which is only the visual system, starting from the eyes all the way back to the cortical regions and back to the eye. That's one FS system: the brainstem, pyramidal, cerebellar, sensory, then urinary/bowel, cerebral, and finally ambulation. These are the 8 functional systems. The combination of the 8 create your EDSS, or the Expanded Disability Status Scale. Each FS score is scored from 0, where no disability, up to 5 or 6, where there are more severe disabilities. Some of them end at 5, some of them end at 6. We'll be talking about these in the next few slides. So the EDSS constituents, as we said, they're a combination of the 8 FS scores, which eventually give you the EDSS number, which is the number that's used in research studies mostly, among neurologists, pharmacists, nurses, physical therapists, and anyone technically who deals with multiple sclerosis patients. So to calculate it, as we said, FS scores range from 0 to 5 or 6, except for the ambulation FS score, which ranges from 0 up to 12. The combination of these FS scores eventually ranges from 0 up to 10. Now, I'm going to start with the visual FS score. So technically, this is where you test the visual system, starting with the visual acuity, where you use a Snellen chart at the distance of 20 feet and you test the patient's visual acuity. Then you're going to test the patient's visual fields, where you see if they have any deficits, check for scotomas or areas where they cannot see clearly, or disc pallor on a fundoscopic exam. Now, putting all these together, as you see on the right side of the screen, the functional system grade 5 plus maximum visual acuity of better eye 20/60 or less, which means that the worse that the visual system is in a patient, or the more deficits they have, the higher the functional system score is. This right away, it's something we with time get used to, but initially we always have our chart next to us to really look at. When you do your physical exam, you're going to find the deficits, if there are any, and then choose the FS system score based on your physical exam. Moving on, the next functional system is the brainstem, which tests the cranial nerves all the way from 1 up till 12. So when these cranial nerves are tested, you test for extraocular movement impairment, eye movement impairment, nystagmus, trigeminal damage, facial weakness, hearing loss. So all of these, again, range from 0 up to 4 or 3 in some of them. Like I said, it's always the same way. The 0 is the best, and going up to 4 is when you have the most disability. Then there's also dysarthria, where you test the speech, dysphagia, you test the swallowing, and other cranial nerve functions that were not mentioned before. Then you have in the bottom the functional system score, which is a combination of these ones, the dysarthria, dysphagia, or the cranial nerve exam, where it ranges from normal up to inability to swallow or speak, which is a 5 again. Pyramidal system tests technically the motor function of the patient, where you're going to be testing the strength in the upper and lower extremities, along with reflexes that you're going to be testing on the patient, and spasticity if present or not, along with the gait spasticity if present or not. The weaker the patient is, the higher the score is, ranging from 0, which is normal, up to 6, which is tetraplegia, or technically 4 limbs which are either weak or completely paralyzed. The cerebellar FS score is when you test for the cerebellar system, starting with a head tremor, then to truncal ataxia, which is ataxia of the whole body when the patient is sitting down. Limb ataxia, where there's ataxia of one of the limbs, either the arms or the legs. Tandem gait, which is where patients walk in a tandem method, where they have their heels to toes, so technically walking in a straight line with their heels touching their toes. Gait ataxia, which you can see when a patient's walking, where they cannot walk in a straight line. A Romberg test, where they stand up, close their eyes, and put their arms up, and they're not supposed to sway. If they start swaying, that's abnormal. And other cerebellar tests, again, ranging from normal up to severe abnormalities in these. Again, mild, moderate, severe is very subjective. That's why it's important for the EDSS to be done by the same person on the same patient at every follow-up. But then with time, you get used to the names and the mild, moderate, and severe grading, and that's when it becomes easier to switch testers. Again, like we said, ranging from 0. Cerebellar has an interesting thing in it. It's the FS system, or the functional system score is the letter X, where if a patient has some weakness in the limb, you cannot test whether they're ataxic or not because of the weakness. So the weakness is a confounding factor. Therefore, if you have weakness present, you cannot really test for the cerebellar test in that limb, and you use the letter X, where it will not really count in the EDSS final score. The sensory FS system, where you test the superficial sensation, vibration at the most distal joints, position sense, and if the patient has a Lhermitte's sign or not, along with tingling. Notice the stars, the asterisks next to the Lhermitte's and the paresthesias or tingling. Those two do not count in your FS system score. But the superficial sensation, along with the vibration and position sense, the worse the superficial sensation is, the higher the score, vibration as well, and position sense. So the FS system score for sensory ranges from normal up to 6, where it's a sensation essentially lost below the head. Then you have the bowel and bladder system, where you don't usually test this. This is more by history, where the patient will tell you if they have any urinary hesitancy or retention, any urgency or incontinence, any need for bladder catheterization. And then there's the bowel dysfunction, where patients are continent or not continent. Based on their history and what they tell you, you grade them if they're mild, moderate, severe, or loss of function. Sexual dysfunction is also something present in patients with MS. You don't usually test for that, but by history you get that. But this also does not count in the FS system score. So the bowel and bladder system, again, it's a system score ranging from 0 of normal up to 6, which is the loss of bowel and bladder function. Now, an interesting thing in the bowel and bladder FS score is that there's a conversion that we do for the score. If you look at the upper part of the slide, you can see that if you have an FS score of, for example, 6, it's actually a converted score of 5. That's the same thing for the visual system. So both visual and bowel/bladder functional system scores are converted to a lower number so that they count a bit less in the EDSS outcome. So you always use the converted score for your final EDSS calculation. Cerebral, so this is a bit of a controversy. This is a very subjective type of exam where you test for if there's depression present or not, decrease in mentation, and fatigue. Fatigue is also very subjective. Therefore, this score is not always used in research studies. You always have to make sure that this is being used to calculate the EDSS or not. If it's not, then you just put the functional system score, but you do not use it in the calculation of the EDSS itself. Ambulation is by far the most important constituent of the EDSS. So technically, the functional system score of the ambulation ranges from 0 to 12. Starting from 0 of unrestricted and 1 of fully ambulatory. When you have a 0 or a 1, it barely affects your EDSS. But jumping to 2, from 1 to 2, your EDSS can jump from 0 or 1 up to 4.5 right away. So whenever you have any issue with ambulation, you have an EDSS of 4.5 and above, which is a worse, technically, exam. 2 is when the patient can walk less than 500 meters, but more than 300 meters without help or assistance. So you technically test the range of walking without the use of assistance. And that's when you really calculate how much they can walk. And based on that, you have your functional system score. I'm going to be talking a bit more about the grades of walking or ambulation in a bit in our calculation of the EDSS. And this is a bit of a summary of the FS scores. Visual is from 0 to 6, and the conversion goes down to 0 to 4. So a 6 on your visual system is actually a 4 in your FS score. Brainstem is 0 to 5, pyramidal is 0 to 6, cerebellar is 0 to 5, along with the X that we talked about when you have pyramidal dysfunction or weakness that affects your cerebellar exam. Sensory ranges from 0 to 6, bowel and bladder also ranges from 0 to 6, but it's converted down to 0 to 5. So your maximum FS score is 5 in a bowel and bladder. Cerebral 0 to 5, like we said, it doesn't always count. So you really have to see if this research study is actually using the cerebral FS score in the EDSS or not. And ambulation, which ranges from 0 to 12, but ambulation again is the most important constituent of your EDSS. And I'll explain why in the next few slides. So this is how you calculate the EDSS. It looks pretty complex, but when you get used to it with time, you know how to calculate it pretty quick. The way I think of it is a 0 EDSS step is when you have 0 in all the FS scores. If you have 0 in all your FS scores, so your exam is completely normal, then your EDSS is a 0. Again, like we said, the EDSS and FS scores are calculated based on your physical exam and neurological exam of the patient, and partly from their history. So a 0
Dr. George, can you hear us?
So it seems that Dr. Saab has an interruption in his connection. So just we'll wait 1 or 2 minutes, and if he did not join again, we will move to Dr. Jaber lecture, and we can always return back to Dr. Saab lecture.
He is reconnecting.
So we apologize for this cut in connection, and go ahead, Dr.
Now?
Your voice is still interrupted. Go ahead.
All right. Is this better? No?
Yeah, it is better now.
Oh, sorry for that. So, all right. So regarding the EDSS, again, we were just saying that 0, 1, and 1.5 is where you have unrestricted ambulation and unrestricted or normal physical exam technically, except with minimal signs that you see on your exam without any deficits that the patient has. But
So again, Dr. Saab get disconnected. I think we'll move to Dr. Jaber lecture, and then he can continue his presentation after Dr. Jaber's lecture.
Thank you, Maya. Thank you, Maya, for this invitation and the
Yeah,
IVPN.
let me introduce you, please.
Sure.
So our final lecture will be delivered by Dr. Jaber Al-Khabouri, who will introduce to us the management of an MS relapse and will give us a brief overview on the MS treatment. Dr. Jaber Al-Khabouri is a senior consultant neurology and deputy of neurology in Khula Hospital, Muscat, Oman. He graduated from Sultan Qaboos University Hospital Medical School in 1994, and he was a distinguished student as he got the Dean Award of Achievement. His medical training was in Royal Hospital and got the award of Oman Medical Specialty Board for the best resident. He passed his MRCP diploma in 1997 from Glasgow. His neurology training was in London from 1998 to 2003 as a specialist visiting registrar. He returned from England in 2004, where he headed the neurology department for many years. He has training in all neurological disorder, but his main interest is multiple sclerosis, headache, and vascular pathology. He also expert in Botox treatment, interpreting EEG and EMG. His research involved oral treatment for multiple sclerosis and use of cannabis in MS. He has published many papers related to multiple sclerosis in Oman, and he is currently the director of the MS Center at Khula Hospital, Oman. Thank you, Dr. Khabouri, for being with us tonight. Please start your presentation.
Thank you, Maya, for this kind introduction, and I thank the IVPN network to invite me. Thanks also for Jansen, and a special thank for the audience who has been, can I share? this is my lecture. I'm going to talk about the relapse definition. I think the previous speakers has set the scenes for me to talk about this topic. This is my disclosure. Now, people have different names for one thing. So one people will call it a relapse, another will call it an attack. So exacerbation, flare-ups, events, and blips. These are names for a similar sort of description by various people. As you can see in the previous lectures, people have been describing relapses, exacerbations, and attacks. So more or less, this mean the same thing. Now, the definition of relapse is basically a clinical finding. The relapse is the hallmark of multiple sclerosis. We've been talking about relapse since MS has come into life in 18 or when Charcot has invented or came up with the disease. Relapses, although they should be distinct neurological events, in practice they are often indistinct or equivocal because it depends on the expression of people's symptoms. So people can over-report or under-report relapses, and you have to take patients' words for that. But in McDonald in 2010, he defined a relapse as patient-reported symptoms or objectively observing signs typical of an acute inflammatory demyelinating event in the CNS, current or historical, with a duration of at least 24 hours now in the absence of fever or infection, which means that patients can have symptoms, new symptoms, or reappearance of an existing symptoms. Now, people have talked about clinical relapse, but we shouldn't forget about something called a radiological relapse. And we take the activity of MS as meaning clinical and radiological relapse. So radiological domain as an increase in lesion load, size of T2 lesion, or T1 GAD enhancing lesions in both the brain and spinal cord. We think that every clinical relapse should be followed or preceded by a radiological relapse. But we have a paradox. We don't really find this close association, and we will come to that later. Now, a typical relapse will usually insidious comes, like for example, a patient will have some pain in the eyes in optic neuritis, pain in the eyes, on movement of the eyes, gradual worsening, at least over 24 hours, maybe 3 days, 48 hours, and then will plateau. These symptoms will plateau for about 2 to 4 weeks, and then will recover about 2 to 4 weeks, total of 6 to 8 weeks. So this roughly the time course of MS relapse. So it's not urgent, it is not sudden change, it's a gradual change. And that's why you have to differentiate MS from a vascular event. Now, people has a few relapses. This was Hutchison in 2012, saying even a mild relapse indicates a need for assessment of the adequacy of disease control. Mild relapses, defined perhaps as prouding minimal impairment with full and speedy recovery, needs an attention as a disabling relapse. This concept, because we think that relapses are immunological attacks, and therefore if immunology happens the same, it doesn't differ between a disabling relapse or a mild relapse. Both are immunological attacks by MS. Now, this was, I think Dr. Riashi has presented this, but in a form. A was a normal brain. In B, what happens, this is an active lesion, an attack, which is supposed to reflect a clinical attack. Usually an Epstein-Barr virus or something like this in a susceptible individual will induce an autoreactive cells because of molecular mimicry. Now, these cells will travel from the blood to the lymph nodes, then into the CSF, and then into the choroid plexus, meninges, and then into the parenchyma. Well, they will set an autoreactive cells and a breach of blood-brain barrier. Now, once the blood-brain barrier, which is the hallmark of an MS relapse, is breached, a second wave will happen. This will facilitate for other autoreactive cells, T cells, to attack the CNS and form relapses. C is a chronic active lesion, and D is a chronic inactive lesions as described. Now, recent clinical trials for DNT have reported a variable relapse rate. Initially, on the old trials, we were seeing 2-3 relapses, but now we are seeing about 1.5 relapses. So in annualized relapse rate, about 0.46 to 1.8, and after the trial, usually 1.18 to 0.49, so half a relapse. Now here it comes. When a patient has a relapse, for example, an optic neuritis, now 70% of MS relapses and in the form of exacerbation of previous symptoms. And here comes the problem, because the patient comes with optic neuritis, in few months, he comes again with another. So 70% relapses in the same territory, brain territory, not necessarily the same limb. Now, a relapse happens when there is a conduction block. When the conduction block, it slows the conduction in the nerves, and you get an eloquent area of the brain, and it produces a relapse. Now we know the frequency of relapses in higher in women and at a younger age, and initially when MS comes, and the relapse rate decreases in time. Most relapses negatively affect the activities of daily living, increases the emotional burden, and causes depression of the patients because he becomes anxious. Now the frequency of relapses increases in the spring and slightly decreases during winter months. Now, MS can happen and symptoms can happen anywhere. But what we have is the typical MS symptoms. Typical MS symptoms as described by my previous speaker. Now, the commonest, this was an MBASE, about 15,000 relapses and 5,000 of patients. They say the commonest relapse is a sensory relapse. The patient will complain of a sensory numbness on one side of the body. Now, this followed by pyramidal, which was explained, spasticity, weakness, brainstem, diplopia, visual, loss of vision, cerebellar ataxia, sphincter, and cognitive dysfunction, which most of us neglecting in the MS world because it's difficult to quantify. But I think we are coming slowly to that, to convincingly that cognitive dysfunction can be considered as a relapse. Now, visual, sensory, brainstem, more in early disease and in younger patients. Pyramidal, sphincter, cerebellar are more common in older patients and in progressive disease. That's why primary progressive MS has more pyramidal and cerebellar relapses. Women have more sensory or visual, men have more pyramidal, brainstem, and cerebellar relapse. Now, we said that the most common symptoms, relapses, are what we call typical relapses. Dr. Jum'a talked about non-specific symptoms like headaches. These are not considered as symptoms of relapse. Now, there are symptoms, what we call relapse symptoms, maybe different. So fatigue is a common symptom in MS, numbness, tingling, walking balance, muscle weakness, cognitive dysfunction, muscle spasm, pain, loss of coordination, depression, heat, and sensitivity. Now, as we said, 75% of relapses are monosymptomatic. They occur in one site. However, there are 25% which have different sites involved, polysymptomatic, occurs in different spaces in the brain, as was talked about. Now, infection sometimes can exacerbate. The risk of relapses increases 2 weeks prior to the infection and until 5 weeks after the onset. 17% of untreated relapses recover with significant recovery. When a patient has a polysymptomatic spinal and an advanced age, regression is usually difficult. Now, all like infection, heat can cause pseudo relapses, and we will come to that, except menstruation, which may trigger a relapse. Now here, a meta-analysis was published in 2020 in Medicine about the results of factors associated with relapses. And you can see from the table that infection is one of the commonest causes of relapses. Postpartum is another cause of relapses. For example, vitamin D, stress is another cause. However, vaccination and trauma maybe not. There's a large confidence interval. So infection, postpartum, and stress are known to exacerbate multiple sclerosis relapse. Now, people talk about topography of relapses. Topography means where the relapse has happened. Is it happening in the brainstem, cerebral, cerebellum, anywhere exactly in the brain? Topography. Even what is the relapse and topography of the relapse will eventually dictate. When we talked about a clinically significant relapse in practice, we mean really any motor relapse, which causes functional deficit, any brainstem relapse, a sensory relapse, which lead to functional impairment, relapses leading to sphincter dysfunction, severe optic neuritis. Now, that is a clinically meaningful relapse. What is a disabling relapse? So these things should be in mind. A disabling relapse is defined as a relapse which fulfills one of more of criteria. It has to affect patients' ability to walk, patients' activities of daily living as assessed by appropriate method, motor or sensory function sufficiently to impair the capacity or reserve to care for themselves or others, and relapses which needs treatment or hospital admission. Now, the problem with relapses is people underreport relapses. For example, in this study in the US, 54 patients has answered no to the question whether they have reported their relapse to healthcare professionals. Now, to an MS care team, there is a less so they report much more, because if you have an MS care team, an MS nurse, people who care for MS, then people tend to report to you much easier than if you are in the general background. And that's what the usefulness of having an MS center. Now, when patients ask, why do you not report relapses? People have said in 57%, not severe enough, HS healthcare professional unhelpful, or didn't tell me what I should, treatment doesn't work well, prefer to manage alone, financial insurance, medication on hand. So these are some of the various reasons. Now, when you have a relapse, what else can it be? If a patient has symptoms, what could it be? Now, alternative neurological diagnosis could be pseudo relapses, which will come later, short-lived paroxysmal symptoms. When I say short-lived paroxysmal symptoms, for example, Rermit's phenomena, electric down the neck, maybe trigeminal neuralgia, maybe sphincter, that doesn't usually last more than 24 hours. These are short-lived symptoms. Transient day-to-day fluctuation in neurological symptoms. For example, if a patient is sensitive to heat, when the heat comes, usually he feels the symptoms get exacerbated. But when the heat comes down, these symptoms should go to their original criteria. Progression, gradual worsening of months, metabolic disorders, neurological manifestations due to other medical conditions that the patient may have. Now, a pseudo-relapse, what is a pseudo-relapse? A pseudo-relapse is an emergence of previous symptoms that the patient already have, not new symptoms, because of fatigue, because of heat, because of infection, because of stress, because of hormones, of medication side effects. Now, this usually starts with the emergence of the cause and finishes with a disappearance, lasts less than a day. And that's the differentiation between a true relapse and a pseudo-relapse or paroxysmal symptom or non-specific symptoms. So you have to be aware. Often these patients go to an A&E physician who patient may report some transient symptoms and can be considered as a relapse. So you have to be careful in saying what is a relapse. Now, relapse does count because people get worse after a relapse. Now, when a MS is, as we said, it is inflammatory and degenerative disease. And there are three factors that make patient worse. Age, because they lose their reserves, relapses, each relapse may sometimes contribute to 0.5 on the EDSS. And what is more important is progression independent of relapses that happen. But the more relapses you have, the more disabled you become. So this was an annualized relapse rate and annualized increase in EDSS. The more relapses you have, the more you get progression in your EDSS. Not only that, but those people with relapses progresses far than people without relapses. For example, in this one, to EDSS worsening, if you have relapses, you worsen more. In pyramidal, if you have relapses, you worsen more. In cerebellar, you worsen more. time to DSS-6, where patients can hardly walk, uses two crutches, is more with relapses. So relapses is important. However, when we analyze relapses over the many years to come, we notice that relapses has a low to medium effect on EDSS progression. It doesn't affect the long term, which we have been trying to predict from these relapses. Now, when a patient comes with a relapse, what do you do? So you should ask him about the date of onset, clinical topography. Is it in one lesion or in two sites? Monofocal, multifocal, visual acuity, visual contrast sensitivity, functional system score, EDSS. Re-evaluate patients after 2 weeks, follow up in 6 months. You may use the SDMT, 9-hole peg test, time 25-foot walk to document relapse. Because in EDSS, you should document the EDSS at the time of relapse, but you should probably examine them in 3 months to make sure that as the relapse accumulated a disability or it was a transient and the patient recovers from that relapse. Now, we come to what we call imaging in relapse. Do we need to image every patient with a relapse? Now, a radiological equivalence of an MS relapse is an acute demyelinating lesion. Most MS relapse plaques are silent. So out of 8 to 9 lesions, only one will cause a clinical symptom. It may be because they occur in non-eloquent area of the brain. So you see many lesions in the MRI, but you don't see a relapse. And you see a relapse, but you don't see an equivalent lesions in the brain. This is what we call a paradox. Now, contrast enhancement is valuable in documenting a relapse, but only positive in 30%. Now, people have been using other things, like giving triple contrast, prolonging the acquisition by the MRI, which may yield much better than just doing a quick MRI. In recent studies, you can get flare with the MRI. Open ring enhancement is typical for MS. Now, we talked about the paradox in MS. MRI studies have shown that about 5 to 10 new matter lesions occur per relapse diagnosis. 30% of patients with MS relapse did not have a GAD enhancing lesions. MRI is not typically not necessary to diagnose an acute relapse unless to rule out an alternative explanation for the change in neurological status to assess the level of disease activity and use of a new baseline. Now, when do you recommend for the MRI assessment in patients with suspected relapse? Obtain an MRI for diagnostic and prognostic purposes during the first relapse. Obtain MRI before treatment escalation and 6 months later to rebase. Obtain MRI in treatment initiation with corticosteroids. Obtain MRI in patients with unclear or non-objective observed clinical signs in whom GAD enhancing lesion must be demonstrated before initiation to complete basically the dissemination in time. Now, treatment. How do you treat a relapse? What is your objective? Now, you treat a relapse because you want to shorten the relapse. You want to make it, instead of 4 weeks, 5 weeks, you want to make it 3 weeks, 2 weeks. You want to prevent the disabilities that may the patient get from the relapse. These are the two things. Now, treatment of a relapse is not just steroids, which more people feel. It's a treatment of the underlying infection, if there is one, which triggers the relapse. Let it recover on its own. Symptomatic therapy, rehab, you may need to rehab. Reconsider that this attack or this relapse is an immunological event, and therefore you may need. Remember that now we change our medications or DMD on just one relapse and 2 MRI lesions. Now, if the patient's on disease-modifying therapy, treating their relapse will respond better than those patients who remain untreated on DMD. So having DMD facilitates the recovery from relapse. So how do we treat relapse? I mean, treatment of relapses with intravenous methylprednisolone or ACTH. ACTH is 8 units per day. Reduce post-relapse disability and shorten the duration of relapse. Maintaining oral therapy after IV administration does not provide additional benefit. Now, there was no difference found between group regarding drug efficiency with administration of equal doses of oral and IV, except in optic neuritis, because there was a trial says that if you give oral steroids, it may not work. However, this may have been challenged recently. Treatment should be applied in hospital in pregnant women because of side effects, children, and elderly, and in presence of hypertension, diabetes, and peptic ulcers. Now, if the patient, you had a relapse, you give him steroids, 3-5 days, the patient did not improve, then you consider another treatment, but give it about 10 days for them to start recovering. Now, we call a patient in remission once the symptoms start to improve, not after the symptoms has improved. So once the symptoms started to improve. Now, if the patient didn't improve, you can use plasmapheresis is a good option for selected patients who are refractory to steroid treatment and who are predicted to have a permanent disability, and IV immunoglobulin usually has no role in relapses. EDSS score were shown to significantly improve on steroid-treated patients in the 3 to 6 weeks after relapse. So you have to review the patient, review post-relapse. It's just as important. Review them in 4 to 8 weeks, determine the level of recovery, identify the residual symptoms, monitor response to steroids, document if they have side effects, monitor response to many symptomatic treatment, discuss whether you need to change their modifying therapy, document the EDSS at that time, maybe in 2 to 3 months, whether the EDSS stays the same at the relapse or has improved. Now, this is talking about relapse. I'm just gonna highlight for the second part about DMD future therapy. When we treat MS, we have 3 parts. We have treatment of relapse, we have disease modifying therapy treatment, and we have treatment of symptoms like spasticity, fatigue, cognitive symptoms, and other symptoms. So these 3 are main important. I've talked about relapse. I'm just going to quickly highlight on DF therapy. Now, since 30 years, we have invented many drugs in MS. Started from first drug interferon in 1993 to the most recently approved oral ponesimide, ofatumumab, in 2021. We have moved from controlling the attacks or the relapses to maybe improving the deficits patients have. More so, there are more drugs, PTK inhibitors, which are under development. So we are getting there. We haven't yet got to treating the whole disease, but we are getting there slowly over time. Now, even some of these drugs have even improved the symptoms of patients. Now, there are different mechanisms behind these drugs. Some of them work on DNA synthesis, like cladribine, teriflunomide, adhesions like the telizumab, so they in the peripheral blood, in preventing the blood-brain barrier, and in the central nervous system. So there are different mechanisms of actions. Now, if you plot efficacy and safety, we always talk about that we shouldn't risking the patients, but we should get the patient the best benefit as the lowest risk. The problem over the last 30 years, people have realized that these highly active drugs, we have invented more drugs that with a less safety signal. So, and there are data that coming through now to say that maybe you should be treating patients on more early with highly efficacy, because once you lose something, you may not gain it again. So this is a plot of how risk efficacy versus safety. For example, bone marrow is highly efficacious, but is dangerous. Interferon, slightly efficacy, but they are more safer. So a risk benefit, obviously with an insurance and how much they can afford. Now we're going to talk finally about a drug which has received a recent approval. Now we had what we call an S1P receptor modulators. These receptors actually segregate the inflammatory cells in lymph nodes, stopping them from going from the lymph nodes and therefore preventing them causing immunological attack on the CNS. We have had things like fingolimod, that we want to siponimod, ozanimod, and ponesimide. These drugs have differences in their receptor selectivity. So for example, ponesimide only works on the S1P1 receptors, whereas fingolimod works on 1, 3, 4, and 5. Now these receptors work in different systems, and that's why selectivity has been introduced to reduce the side effects. In Fingo, you have to admit a patient for 6 hours for heart monitoring. In other drugs, they are less, and they may have caused others. Now, ponesimide, as we say, is a highly selective S1P receptors with little or no relevant effect on other S1P receptors. So you can see it is more selective on S1P1 receptors. Now, it was approved from its Optimum study. This was its main study that has compared with teriflunomide. So this was a head-to-head comparison, ponesimide 20 milligram to teriflunomide 14 milligram. Now, ponesimide has significantly reduced annualized relapse rate by about 30%, 30.5% compared with teriflunomide 40 milligram. So there's a significant effect on relapse above and beyond what teriflunomide usually causes, which is about 30-35%. Now, not only that, but ponesimide reduced the number of new inflammatory brain lesions by about 56% compared to teriflunomide 14 milligram, not only on the radiological and on the clinical, but also on confirmed disability worsening. So we know that teriflunomide has succeeded to reduce disability in its 2 trials, the original trials. This has produced a 16% lower for ponesimide as compared to teriflunomide. This result was, however, not statistically significant. And the reason, because most of the patients in both arms did not progress in the trial. Now, so in those patients with an EDSS of less than 3, ponesimide reduced annualized relapse rate by 47% compared to teriflunomide. Change in fatigue. One of the drugs that reduces fatigue, which is a very disabling symptom in MS, in ponesimide group. Improvement in fatigue observed of previously treated naive patients benefited with ponesimide versus teriflunomide in group and treatment naive patients. Yeah, you have to be aware it can cause some slight ALT as well as others. It is more or less the same, but if you compare ALT to more than 8 times, about 0.7 in ponesimide, whereas 2.1 in teriflunomide. Now, this has an advantage. The elimination half-life of ponesimide is only 33 hours. So you can, lymphocyte count returns to 1 week. You remember, if you want to change a drug from Fingo to other, you have to wait for the lymphocyte count to come up to 0.8 or 1 to start the treatment. So it has a potential use in managing side effects, infection, vaccination, and the big thing, you can treat earlier and you can treat as a first line because the lymphocytes can be normal in 1 or 2 weeks from treating it. Now it comes in a coated tablet, 20 milligram, and there is a titration. The company make a pack, and then you can give them a patient reasonable. So in conclusions, Optimum is the first pivotal trial to demonstrate superior efficacy of oral DMT over another oral TNT, significant statistically significant effects of ponesimide versus teriflunomide has been shown on relapse rates, inflammatory lesions, and stabilization of fatigue. Safety have been more or less the same as teriflunomide. This is my last lecture. Thank you very much for listening, and I'm open for questions.
So thank you, Dr. Al-Khabouri, for a comprehensive presentation and an excellent introduction actually for our second module of this course, which will discuss all the available MS treatment, their mechanism of action, safety, efficacy, and the most updated MS guidelines for the treatment of MS. So we'll be taking some questions. So the first question, how COVID-19 infection affected MS patients? So did they had more attacks? So patients who experienced COVID, did they had more MS attacks?
Well, COVID over the last 2 or 3 years has produced many neurological symptoms, from encephalitis to meningitis to Guillain-Barré syndrome to other symptoms. It also, COVID is an infection. As we reported in my presentation, infection causes an increase in the relapse rates in people with multiple sclerosis, as well as other infections. So it did increase the relapse rates in people with infection, with MS, yes.
Another question, is stress a trigger for MS attack?
So from that study that you have quoted, and from study actually presented in Lebanon by Dr. Yamout during the war period, this has shown, stress has shown to increase the relapse rates. So yes, the answer is yes. That was approved by Western and people in the MENA region, has demonstrated that that stress could induce, as you have shown in the meta-analysis that I presented. In the there are three main things. There are the infection, the stress, and the postpartum. These are the three main things that causes increase in the relapse rates in people with multiple sclerosis.
And what about the risk of relapse or the rate of relapse during pregnancy?
Well, usually pregnancy, we have been following that during pregnancy, the relapse rates comes down, especially in the third month. So this has been demonstrated in many times, although it was challenged recently, but we think that a relapse rate decreases during pregnancy because the patient or the MS or the lady usually goes into a different immunological profile. But the problem happens post-delivery, where the relapse rate increases. So in answering this question, the relapse rate decreases, especially in the third month, and increases postpartum.
Thank you, Dr. Al-Khabouri, for being with us tonight. So we will continue now Dr. Saab lecture about the disability status scale and the multiple sclerosis functional composite. Please go ahead, Dr. Saab.
Hello, and I apologize again for the network difficulties that I had. I hope we're all back to this. So as I was saying, an EDSS step of 0, 1, or 1.5 is usually something with no deficits at all, and where you have either 0, where you don't have any findings on your exam, 1 or 1.5, where you have minimal findings without any objective weakness, dysfunction, or 2 is where you start having disability. But starting from an EDSS of 2 up till an EDSS of 4, you are still in a patient who is fully ambulatory, means they can walk at least 500 meters without assistant, and technically they have no problem with that, but this means that they are still restricted, but they can walk more than 500. So EDSS 2 till 4 is a patient who can walk 500 meters at least. Moving up, after that, we go to an EDSS of 4.5. That is where you start having a difficulty with ambulation, and patients walk 300 to 499 meters. Technically, they can't walk 500 meters anymore. EDSS of 5 is where they can walk 200 to 299 meters. And so on from 5.5 up to 8. 6 is where they start needing assistance, whether a cane or a crutch. 6.5 is where they start needing a wheelchair and on. 7 and on is when they need a wheelchair, and these only differ by how much they can technically walk outside of a wheelchair, whether it's 5 meters or less, and how much assistance they need to transfer from bed to chair. So this is the full EDSS, like we said, 20 steps from 0 up to 10. 10 is an EDSS of death due to MS. 0 is a normal neurologic exam. So it's a variety of FS scores, like we said, that are calculated together to give you an EDSS. This is an EDSS summary I'm going to give, which is 0 is a normal examination, 1 or 1.5 where you have signs only on your exam, but you do not have any deficits found on the exam. 2 to 4 is where you have deficits on exam with a normal ambulation. 4.5 to 5.5 is where they have decreased ambulation, but they can still walk without the need of assistance. 6 is where they start needing a cane. 6.5 needs a walker or a wheelchair. 7 and 8 are wheelchair bound. 8 to 9.5 are bed bound, and 10 is death. So in conclusion, EDSS is a language used to stratify patients according to deficit. It's a combination of FS scores, like we said, 8 FS scores combined to give you an EDSS of 20 steps from 0 to 10 with 0.5 increments. It's a universal grading system that's used in research studies and between clinicians or people who deal with patients with MS. And EDSS is used to guide therapy, especially in the beginning or during follow-up of disease. These are my references, and I thank you for your attention.
Thank you. Thank you, Dr. Saab, for your presentation. So I have 2 questions. So the first question, what are the limitations of the EDSS?
So the biggest limitation I find in EDSS is mostly in progressive patients who are already wheelchair bound. patients who are wheelchair bound and on, the EDSS increments are not very big, and it doesn't really give us a wide. So a patient can stay at an EDSS of 6.5, which is wheelchair bound, but technically be worsening, although their EDSS is not changing. That's technically the main limitation I find. And there are some subjective stuff that are not really included in the EDSS, like the symptoms patients have that what I assume have been talked about or so, and their management.
Yes, I have another question, and please, Dr. Jaber, stay with us because I have one more question for you. So, Dr. Saab, how frequently should we perform the EDSS?
I would say a minimum of twice a year. And whenever a patient has a relapse, or if they have a relapse or new findings, that's when an EDSS should be documented to technically see if the patient improves after treatment with steroids, whether they're given or not. It's important to document that this EDSS was after a relapse, and then a few weeks later, up to 6 months later, to really assess for improvement or not.
Dr. Jaber, since you talked about relapse and Dr. Saab talked about EDSS, is the EDSS sensitive during a relapse, or is it sensitive to detect a clinical relapse?
Well, we divide relapse into mild, moderate, and severe. So moderate to severe relapse usually will have an increase in EDSS. When we talk about mild relapse, we mean about mild sensory symptoms, mild maybe impairment of that will not increase the EDSS significantly. So most of the moderate to severe relapse does increase in the EDSS. However, you should, once you give them steroids, for those who are moderate to severe, you should reevaluate them in 3 months because the EDSS might come down. So the patient might recover. So don't depend on an EDSS that happened during a relapse, but reevaluate them in 3 to 6 months to document that its EDSS has remained the patient, or the patient did not recover from the relapse, which has increased their EDSS, meaning a significant relapse.
And a final question to you, Dr. Jaber. So is a patient with ophthalmic disease contraindicated to receive S1P receptor modulator like fingolimod or ponesimod?
Usually we send patients to get their macula tested. So any drug in MS, usually we do what we call a baseline testing. Yeah. So we do a varicella zoster. We have to make sure that they're immunized. We send them to ophthalmology to do the macula. If the patient has a macular disease, usually it's a contraindication to giving. So it's only macular disease that usually in contraindicated in people for fingolimod.
So it's fine to give ponesimod or fingolimod with patient who has ophthalmic diseases, but the only contraindication is for macular edema. So
especially for macular disease.
So with this, those were the questions for Dr. Saab and Dr. Jaber. Thank you so much for your participation. And we'll move to our final session, which is a special and interactive one, during which you will test your knowledge, and it will be presented by Mrs. Joelle Massouh. Joelle will share with you a series of cases and multiple choices question, which will consolidate all what we have learned today from our esteemed speaker. Mrs. Massouh is currently the clinical manager of the Neurology Institute and the MS Center at Harley Street Medical Center, Abu Dhabi, UAE. Previously, she was the nurse in charge at the AUB MC MS Center in Beirut, Lebanon for more than 10 years. She is the first nurse and healthcare professional in the Middle East to be double certified as MS multiple sclerosis certified nurse and a multiple sclerosis certified specialist. She is a member of the International Organization of Multiple Sclerosis Nurse, IOMSN, and a board member representing the Middle East on the Multiple Sclerosis Nurses International Certification Board, which was established to develop criteria for certification and recertification and administer the certification examination for MS nurses. Mrs. Massouh is also the nursing program coordinator of the MENACTRIMS Congress, responsible for organizing the nursing session annually at this Congress with a mission of advancing the specialty of MS nursing in the MENA region. In 2019, Joelle was awarded the inaugural International MS Nursing Leadership Award by the IOMSN at the annual Consortium of Multiple Sclerosis Center Congress in USA, an award which was given for the first time. It's always a pleasure to have you, Joelle, as a speaker. The floor is yours.
Thank you so much, Dr. Zainuddin. It's a pleasure to always be hosted by you. And of course, you do a great job moderating these amazing webinars by IVPN. Thank you for sharing the knowledge, and thank you for all the speakers who have preceded me for their eloquent talks. So my talk would really wrap up by giving two case studies and by doing some multiple choice questions, which will be interactive. We want your interaction. Thank you for all the attendees who are still with us. I think we've maintained a good level of attendees till now. So we will start with a case study, then we will do some questions, and they will be poll questions. So we will want your interaction and your answers. For the case studies, I would like to see if you can give us some answers in the chat box and give us your interactions as well. So these are my disclosures. We will start with the first case. So Amal is a 28-year-old woman diagnosed with RRMS, relapsing remitting MS, 3 years ago. And she presented to the MS center. She has been taking subcutaneous interferon beta 1A for 2 years with an inconsistent routine of injections. So she has not been compliant, and she has a minimal healthcare follow-up. She does not follow up properly with her providers. She lives with her husband. She works full-time, and she has a very busy social life, as many 28-year-olds. She barely gets any sleep, only 4 to 5 hours of sleep each night. She also doesn't have a good, healthy diet. She eats irregularly. Her medications consist of her disease-modifying drug, her DMT, which I mentioned is the interferon beta 1A. She takes a lot of over-the-counter headache medications. She also takes an oral contraceptive medication, and she also takes modafinil, 200 milligram BID, which is a medication given for fatigue in MS. So if you'll attend more of our lectures on treatment of MS and specifically symptomatic treatments of MS, you'll be more familiar with it if you're not at the moment. So now she's presenting with a complaint of nausea, vomiting, dizziness, and severe fatigue. Her neuro exam is negative except for a positive Romberg test. So her balance is off. And of course, if you've listened well to the EDSS lecture by Dr. Saab, you know what a Romberg test is. Her urine analysis is positive for leukocyte esterase. Her vital signs show normal blood pressure. Her heart rate is 100. She is afebrile. Her lungs are clear. It is to be noted that her last menstrual period was 6 weeks ago. So here I want your input, if you can share a little bit in the chat box. So what are some of the issues we want to rule out immediately with Amal? If anyone can share a little bit, I'd be happy to hear your input in the chat box or in the Q&A, whatever you want. So I'll show you the slide before so that you remember the case. What are some things we want to rule out with this patient? So Hossam is telling everyone that chat is activated. Yes, thank you, Rilla. UTI. Pregnancy, yes, Amal. What else? Infection, definitely. Okay, one more thing. If you listen to the relapse lecture, I kind of gave the answer away by Dr. Jaber. Yes, attack, relapse, all the definition, all the terms Dr. Jaber gave for relapse. So, pregnancy, right? She has nausea, vomiting, all those kinds of symptoms. UTI, we want to rule out an infection. She has, she has tachycardia. She's afebrile, okay, but We also want to rule out an acute relapse versus a pseudo-relapse, right? And what is a pseudo-relapse? As Dr. Jaber mentioned, when patients present with symptoms, but we're unsure if an infection is triggering these symptoms or not. So we want to know, does she really have an actual relapse? Because she has some neurological findings. Her Romberg test is positive, but is it an infection that is triggering a relapse or not? Okay, let me see what else you guys mentioned. Side effects of MS drugs. Okay, well, I mean, she is taking
infection or UTI.
Yes, and pregnancy. Okay, so I think we covered all the points. Sorry. Second point I want to talk about. So we said she's like not living a very healthy lifestyle, right? So what are some health and wellness areas we need to discuss with Amal? What are some things we need to, as healthcare professionals, you know, as doctors, pharmacists, nurses? I think we also have physiotherapists with us. I know we have physiotherapists with us. What are some things we need to emphasize for Amal to improve her quality of life and her wellness? Lifestyle modification, sleep problems, true. Daytime routine and nutrition, right? We have to improve all those for her. Okay. Definitely sleep. We have lots of answers on sleep. So sleep hygiene, that's one of your top answers. Compliance to medications, thank you. So adherence, we love the word adherence as well. Adherence is even more engaging than compliance, okay? Because compliance is kind of passive, adherence is more interactive. We want patients to adhere to their therapies. Physical activity, definitely, okay. Conservation of energy, I like that a lot. Great answers so far. So diet, adequate fluid intake, exercise, we want to emphasize those with Amal, and adherence to DMTs. All right, so I think we're doing perfect with your answers, and I think we covered everything. Someone mentioned vitamin D as well, great point. Stress, right? Okay, let's see if there's something else. Someone's emphasizing the mental symptoms as well, very important point. Mental health is very important. How common depression is 50% of our MS patients. 1 in 2 patients, 1 in 2 MS patients will have depression at some point in their life, in the course of their MS disease. So depression is very common in MS. Anxiety is a little bit less common. Fatigue is 90% of our MS patients will have fatigue. So this is an answer to your question. And that will be probably more discussed when we have lectures on symptomatic management of symptoms. And I'm sure Maya will cover those in lectures later on. What else? Mindfulness, meditation, those are very important points as well. Okay. Now, to wrap up the first case study, so some points we need to emphasize to our patient, to Amal. There is a probable impact on possible medications, some medications she might be taking, and specifically modafinil, on the efficacy of oral contraceptives, okay? So there might be an impact on how much effective these oral contraceptives might be. So modafinil might decrease the efficacy of oral contraceptives. So question mark, is she pregnant or not? We need to, she has to undergo a pregnancy test, definitely. There might be an impact on her excessive use of over-the-counter headache medications. We need to discuss that with her as well. And of course, most importantly, her adherence to DMT. So we always say drugs do not work in patients who don't take them. If she's not taking the drug, it's not going to work. So if it's not possible to improve her adherence, and we would like to have a high adherence, if it's not possible to improve the adherence, we really need to consider switching DMTs. At this point, this is not 1990s anymore. At this point, we have 15 to 20 FDA-approved drugs in MS. There are so many options. We can change our patient to an option that works for them. This is optimizing treatments of MS. This is the era where we can personalize medicine for MS, give our patients the treatments that work for them. So let me see some of your points before we move. A lot of focus on relaxation and mindfulness. I agree completely. This is the concepts of complementary medicine in MS, definitely. Okay, so here I will probably need the assistance of our IT. Yes, thank you, Hussam. So we're going to start with multiple choice questions. And here we're going to give you like 30 seconds to answer each question. So we'll start with the first question. When teaching patients about RRMS, relapsing remitting MS, the healthcare professional should describe first, a remission as a time of no neurologic activity, so which is the correct answer. The condition, RRMS, as indicative of a mild disease, or the condition as steadily progressive, I'm sure you saw the rest, or the relapse as a new onset of neurologic symptoms lasting greater than 24 to 48 hours. So which is the correct answer?
Please, dear audience, vote, so the session will be more interactive and your input will add to this session. So please try to vote by clicking on one of the choices on the screen. So then we can come up with the statistics, not on the chat box.
Yes, and this exactly, and the multiple choice questions, vote on the poll on the screen, not in the chat box, so that we get your percentages.
Okay, I will stop the poll now. I'm sharing the results now, Joel.
Yes, okay. So this is the right answer. Most of you answered correctly. So a relapse is a new onset of continuous neurological symptoms that should last at least 24 hours and more. So RRMS is not steadily progressive, and the other multiple choice answers or options do not really fit the answer. So a remission is not a time of no neurological activity. Even in remission, there is neurological activity as well. Okay, I'm going to go a little bit faster because I don't want you to, spend the whole night with us, and I want it to be a little bit more interactive. Second question, MS is best described as which of the following? Demyelination in the central nervous system, lesions in the peripheral nervous system, alteration in neuromuscular function, or reduction in brain volume. And this one's easy, I think. And answer in the poll, please, not in the chat.
5 seconds to go. Okay, I'm stopping the poll now and sharing the results.
Okay. Also, most of you answered correctly, and A is the right answer. Okay, so the hallmark of MS is demyelination, and the keyword is central nervous system, CNS. Next question. Onset of MS usually occurs in persons between the ages of 50 to 70, 40 to 50, 10 to 30, 20 to 40. Many of our speakers mentioned this, so you should also be familiar with it as well.
5 seconds to go. I'm sharing the results now.
Okay. Also, most of you answered correctly. 60% almost answered D, which is the correct answer. Next question. So, on onset, so in the beginning, MS follows the relapsing remitting pattern in approximately what percentage of patients? In 50% of patients, in 85% of patients, 30%, or 15%?
5 seconds to go. I'm stopping the poll now.
Okay, this was a bit tough, I guess. Everyone answered almost equally, but most answered wrong. So I guess maybe they didn't understand it properly. So most people, 85%, will start in a relapsing remitting pattern. So most MS patients will start in a fashion of having relapses and remissions, and then they might proceed to having progression, and they might become secondary progressive. A small portion, like 15%, 10 to 15, will start progressing from onset, which is the primary progressive pattern of disease. Next question. So disease-modifying therapies should be started early in the disease because they do all of the following except decrease relapse severity, reduce relapses, reverse MS symptoms, or delay progression of disability. So the keyword is except here.
Five seconds to go. We are stopping now.
Okay, this one, we got good percentages on it. True. So it's difficult to have, we want to reach disease-modifying therapies that reverse MS symptoms. And this is the future of DMTs. We want remyelinating therapies that might be able to reverse MS symptoms. Next question. So as part of continuing care for patients with RRMS who have experienced a relapse, the healthcare professional will need to recommend an immediate DMT switch, assess the patient's adherence to the current DMT, advise the patient to take a drug holiday from the DMT, or tell the patient not to be concerned at this time. And you can think of the case we just discussed as well.
Five seconds to go. And we are stopping now.
Okay, so first step is to always assess adherence before we decide on anything else. So most of you answered correctly. Okay, so I'm going to go through another case, an interesting case to discuss. So Ahmed is a 41-year-old man with relapsing remitting MS. He developed his first symptoms in 2009 and was diagnosed in 2011. He has been maintained on IM interferon beta 1A since November 2011. He first performed an MRI for severe headache in 2001 when they discovered white matter lesions. Then in 2006 and 2008, he developed some visual disturbances in the sun, and his MRI again showed white matter lesions, but he was completely asymptomatic. So at that point, it was diagnosed as what we call radiologically isolated syndrome, RIS. In 2009, he started developing right lower extremity weakness. He described it as his knees were buckling, so he was like falling, his knees were buckling. It was worse upon walking, and it was relieved by rest. In 2011, he was worked up officially at an MS center and diagnosed with MS, and then he was started on a DMT. So there was a bit of delay in diagnosis. Since then, he has been maintained on IM interferon beta 1A, and there was no clinical evidence of disease since then, and only one new lesion on MRI in the cervical spine. At some point, he also tried pegylated interferon, but did not tolerate its side effects at all. So there was a switch just to decrease the frequency of interferons from once weekly to once every 2 weeks, but he did not tolerate side effects. During a visit to the MS Center in April 2019, he reported subjective worsening in his lower extremity weakness, but there was no objective evidence on exam. So on the EDSS, there was no change. His MRI at that point as well did not show any new lesions. Sorry, and he was advised to perform physical exercises to strengthen his muscles, and he was also given a trial of a medication we use to improve walking. It's called fampiridine. Sorry, I apologize. In October 2020, the patient was experiencing worsening of his right lower extremity weakness upon exertion. So it was like fatigability, worsening of his weakness after specifically like 10-15 minutes of exertion. And he had difficulty doing quick or sudden movements with his right lower extremity. So it was small, imperceptible weakness, specifically upon doing like sudden movements. He wanted quick movements with his, like playing certain sports, moving his extremity, like through football or things like that. He also started reporting a 1-year history of a weaker urinary stream. Again, it was recommended that he starts a trial of fampiridine for 2 weeks. In February 2021, the patient reported on the phone, because this was through the pandemic and it was more difficult to assess patients physically. He started reporting intermittent numbness and dysesthesias in his left leg for 3 days. Then finally, he presented again in July 2021, here with worsening of his right lower extremity weakness. And finally, he was actually started on fampiridine. He was able to secure it. He improved significantly on fampiridine, which is a symptomatic treatment. So it's not a disease-modifying drug, it's a symptomatic treatment. And here he was deemed that he was entering the progressive phase since late 2020 based on his clinical history. So the patient has reported he has been worsening since 2020. Now here on neuro exam, his EDSS score was 2.5. So as if you remember what the different functional system scores Dr. George mentioned, different FS scores, how we measure them, the motor weakness, the sensory FS score, the vibration. The total score, because we have 2 FS scores that are 2, it adds up to 2.5. It was actually 1.5 1 year ago. So there was a disability progression of 1.5. His multiple sclerosis functional composite, which we also do for all our patients, was not much worse. His 8-meter walk was 4 seconds. It was stable. His cognition was acceptable, and his 9-hole peg test, which is a measure of upper extremity function, was good as well. Now, what are some management considerations for this patient? So, as we said, EDSS shows confirmed disability progression. Now, his EDSS progression might also correlate, as we can see, with his subjective complaint of gait worsening since 1 year. So he had before several subjective complaints, but they were not objectively measured. So we need to have a correlation between subjective worsening and objective worsening. For this patient, he has a stable MRI, but there's subjective and objective worsening, and he has absence of clinical relapses. So I would probably not ask you to try to guess or predict what are some of the things we might think about, because these are concepts that might not be very familiar with you. But Dr. Jaber mentioned it a little bit, which is the concept of PIRA, okay, which is progression independent of relapse activity. So here we have to think: is this patient in PIRA? Is this patient or versus early secondary progressive MS? So we have to weigh these issues. So we have many supporting factors for this patient to not leave him on the current therapy, okay? So here we are thinking about this patient over these past several years. He has these like red flags to not keep him on therapy. We also have the concept of the prognostic factors of having this patient that first, he's a male as well. He is not very young. So there's the age factor, the gender factor. All these are like negative prognostic factors. So the decision here was to shift to escalate therapy and to shift to a B-cell depleting therapy for the probable diagnosis of progression, and to shift to rituximab or ocrelizumab. So this is just to give you a different case and to give you an idea of how the thinking goes in a different case as well. So we're going to move to multiple choice questions. Let me see your energy again. Which of the following statements about MS is correct? Life expectancy from time of diagnosis is generally 10 years. Age of onset of MS is usually 40 to 60. MS affects more women than men. Recent development of a cure for MS has brought hope to patients and their families. Which is correct?
5 seconds left. Okay, we are stopping now.
I hope everyone answered this one correctly. Okay, most did, but not everyone. I expected more. I don't know if we have more women or men attending, but yeah. So this was mentioned before in maybe the first lecture, I think, and probably in more than one lecture. Definitely MS is more a disease of women than men. So the incidence and the prevalence is higher in women than men. Definitely, okay, so let me correct some misconceptions. Life expectancy from time of diagnosis is definitely not 10 years. So you don't die 10 years after you have a diagnosis of MS. Life expectancy is shortened by a few years. So the general life expectancy is shortened slightly by a few years, but you don't die 10 years after having MS, definitely not. Age of onset is not 40 to 60. We said before it's 20 to 40. And there's no cure for MS as of now. There are many treatments, but no cure. Okay, next question. All right, think about this. Which of the following statements about the pathophysiology of MS is true? The lesions associated with MS are particularly prevalent in the optic nerves and the gray matter of the spinal cord, brainstem, cerebellum, and cerebrum. Or loss of myelin sheath disrupts electrical conduction within the CNS. Or MS is thought to occur secondary to a bacterial infection. Or myelin loss occurs only in the spinal cords of people with MS.
5 seconds left. We're stopping now.
So I expected people to be lost between the first two, which is logical, but it's actually the second option. So as we said, the keyword is also the CNS, and the hallmark is loss of the myelin sheath. What happens is demyelination, and this is what disrupts the electrical conduction within the CNS. The wrong what should have tipped you off that it's the wrong answer in the first one is gray matter. So it's really the white matter is the most important thing. White matter lesions are, and the white matter is the most important area that is damaged in MS. There are some gray matter involvement, but it's really not the most correct answer. Next. Which of the following is most implicated in the pathophysiology of MS? Schwannomas, loss of oligodendrocytes, astrocyte dysfunction, or synaptic plasticity?
Five seconds left. Okay, we're stopping now.
Okay, good. So most of them got this right, and I'm happy because it's a lot to think of at this time at night. So yeah, oligodendrocytes is very important for us to remember in the pathophysiology of MS. All right, next question. The symptoms of MS result from inadequate lymphocyte production, proliferation of myelin, inadequate inflammatory response, or demyelination and scarring of nerve fibers.
Five seconds left. Okay, we're stopping now.
All right, most of everyone got this right. So the most important thing is the demyelation and the loss of axons or the scarring of the nerve fibers. This is where the symptoms of MS will come from. Next question. So I touched upon this, so I think you should know this, most of you. Which of the following tests is utilized to determine upper extremity function? Finger, nose, finger assessment, Ashworth scale, minimal record of disability, or the 9-hole peg test?
Five seconds left. Okay, we're stopping now.
I think you got confused by the finger, nose, finger assessment. It's the 9-hole peg test. So this is part of the multiple sclerosis functional composite. And the MSFC is made of 3 parts: the 8-meter walk test, which is to assess walking, the SDMT, which is to assess cognition, and the third part is the 9-hole peg test, which is a test to assess upper extremity function. So finger, nose, finger assessment, they are specifically to assess like cerebellar functions and not to assess upper extremity function per se, like fine motor movement and upper extremity function specifically, okay? So this is probably our last question. So which of the following should be discussed with a patient with an EDSS score of 7.5 experiencing worsening MS? And if you remember on the scale of 0 to 10, that an EDSS of 7.5 is quite high. So what do we discuss with such patient? Do we discuss corticosteroids, acute care facilities, realistic life planning, or immunomodulatory therapy?
5 seconds left. Okay, we're stopping now.
Okay, so half of you answered immunomodulatory therapy, which is not the right answer, because at this point, a patient who is very disabled, okay, so this 7.5 is a very high EDSS. So we don't have a lot to modulate at this point, okay? So it's tough to fix something at this point when patients are left with very little reversible symptoms. So, and we specifically said they are still experiencing worsening MS, so they are still worsening. At this point, we have to discuss realistic life planning with the patient. We have to discuss what do they want out of their quality of life. These are patients who are who are wheelchair to bedridden and are have barely upper extremity use, some bare minimal upper extremity use. So we have to discuss what do they want out of their quality of life, how we can help them maintain quality of life and dignity. So with this, I think I'm done. And I think we wrapped up a few concepts. I know we discussed a lot of things today, which is why some questions were a bit tough, but I'm happy you stuck around till the end, and I'm happy to answer any questions.
Thank you, Joelle. And it was, as we said in Arabic, ختامها مسك, and you really wrapped up the key point in each presentation. And for your last question, I would like to remind our audience that there will be a part 2 for this webinar, which will be scheduled in July, and will discuss the management of multiple sclerosis, from symptomatic management to disease-modifying therapy in different phenotype of MS, progressive MS and relapsing remitting MS. So stay tuned and join us on July to know more about the treatment of and the management of MS. So actually we have questions for you, Joelle. So one of the questions, the speakers mentioned physical symptoms of MS, but what about psychological symptoms? So depression, mood swings, how to manage, and how common we have depression and mental health diseases concomitantly with MS?
Yes, so I answered a little bit that during my presentation. I said depression is almost 50% common in MS. 1 in 2 patients will have depression during the course of their disease. Anxiety is a little bit less common. Fatigue is will be present in almost all of our patients. Almost 90% of our patients will deal with fatigue at some point of their disease. So mental health is very, very important in MS, and we need to discuss it with all of our patients. We need to be the ones to initiate the discussion, because sometimes it's difficult for patients to initiate the discussion themselves. They think something's wrong with them, that's why they're feeling that. So it has to be, we should approach our patients and ask them these questions at every visit. It should be part of our regular questions that should be screened at every visit.
Thank you again, Joelle, for an amazing session.
Thank you.
And at the end of this webinar, I would like to thank you, our esteemed speakers, for being with us tonight. Jensen for supporting this well-needed activity, and the big thank you goes for you, our attendees, for staying with us until the end. I want to remind you that you will receive your certificate of attendance by email within 1 week from today. If you miss any part of this webinar or you would like to revisit the lectures, you can check our IVPN NeuroPsychiatry library, where we post all the recordings. Follow us on our social media platforms and stay tuned for more activity during this month. Our next webinar will be held next week on May 17 and will discuss women's issue in MS, from conception to pregnancy and beyond. All the details will be shared on our social media platform very soon. Have a good night, and until we meet again, stay safe.